good morning. It looks like we have a quorum, so we'll go ahead and get started. I'll call the February meeting of the Commission to Combat Substance Use Disorder. The minutes were distributed prior to the meeting. Is there kind of a motion to approve the minutes? Second? Second. Perfect. All in favor? Aye. Thank you. The minutes from the November meeting have been approved. It is my pleasure to introduce our first speaker, Andrew Fuqua. Andrew joins us today as the newest member of our DMHA team, serving as the division's first ever peer support manager. In this role, he's leveraging his lived experience to help train our growing peer workforce. So I've invited Andrew to share with the Commission how he's arrived where he is today and celebrating 4 years in recovery. So thank you.
Good morning. Thank you for having me here and giving me a chance to share my story. My name's Andrew Fuqua. I'm 34 years old and I have 2 beautiful daughters. I live on the south side of Indianapolis in the Beach Grove, and I'm a person who lives life in long-term recovery. I live with multiple mental health diagnoses as well as substance use disorder, although it's actively in remission. I was raised in a small town about 30 minutes east of here named Shelbyville. I was raised primarily by my mother. My father was around, but he was often in and out of the legal system. My father suffered from alcoholism and was not available as much as I would have liked. My childhood was pretty good. We grew up much poorer than my peers, but as far as love and support, I couldn't ask for more. Looking back on life now, there were plenty of risk factors and warning signs that I wasn't aware of. As a child, I always felt the need to fit in. I felt like it was a daily battle just to be liked. I was completely unaware that I was suffering from depression, anxiety, and a mood disorder. I started experimenting with substances in middle school, starting with alcohol and marijuana, progressing all the way to prescription medication. When I was introduced to prescription medication, my need to fit in no longer existed. I no longer cared what people thought. After high school, my behaviors continued to worsen, and I eventually was introduced to heroin. My methods of ingestion also progressed. I started with taking pills orally, then nasally, snorting them, and eventually led to injecting these substances. The need to fit in, lack of consistent father figure, my mental health and substance use disorders led me to quite a bit of legal trouble. Growing up, my mentors were always much older than me and were involved in illegal activity. I was first arrested for drinking at the age of 15. Those troubles continued until I was 29. My life was madness. I was stuck in a vicious cycle of jails and institutions. It was full of every kind of pain you could imagine, and my life was very dark. I lived my life expecting to die from this disease, and I just accepted that was the way it had to be. Throughout 9 different arrests for substance-related charges, I was never offered any type of treatment. Honestly, I was kind of labeled a menace. The last 5 years of my battle, I sincerely did not want to use substances again, and along with my family, I was often relieved when I was arrested. I was safe for myself inside institutions. I would go out and have my mind set on living life right and taking care of my children, only to have a worse return to use, followed by more pain and eventually incarceration, again and again and again. Over 5 years. Sounds insane, doesn't it? In 2019, I was arrested for the 10th time. I was finally offered treatment inside the jail. It was Shelby County Jail's jail intervention program. The program consisted of 90 days inside with a variety of programming, followed by 6 months community corrections upon release. The programming consisted of therapy, peers, community health workers, and even nearby pastors from local churches. The inside portion of the program consisted of basic knowledge and the teaching and developing of effective coping skills. Upon completion, I chose to seek further treatment and live in a sober living facility here in Indianapolis. The facility was called a Progress House. I learned how to apply the skills and knowledge I learned inside the jail intervention program to my current life and finally identify and change old behaviors that fed the cycle of madness. During this time in programming is where I found out I really wasn't crazy. Much like we experience after achieving an important goal, addictive substances send a message to your brain that tell you feel good and enjoy the substances. In these pleasurable situations in your brain releases dopamine, which is a neurotransmitter. Unlike achieving a goal, addictive substances flood your brain with rapid, large amounts of dopamine. The dopamine also interacts with another neurotransmitter called glutamate. When this happens, the drug takes over your brain-rewarded learning system. This is the part of your brain that links life-sustaining activities to the need for human survival. In summary, I learned That extended use of substances rewired my brain to tell myself that they were no longer a desire but a survival need. Since that last incarceration and my first opportunity for treatment, I have been substance-free and living in active recovery. My life has improved tremendously. I live life daily doing things I never thought possible for myself. And the best part of all this is I get the opportunity to share my knowledge and awareness of these topics to other individuals through similar situations with attempts to provide change, a chance for hope, or a chance for change, I finally found my purpose and passion in life. I've worked in and out of just about every part of recovery possible. I was a part of Eskenazi's first mobile crisis team. I worked with them to develop and process and procedure that worked well for the company and the clients they serve. I worked in detox, early residential, and adult outpatient. I was also given the chance to work inside the same sober living facility to help me find my purpose. I worked hand in hand with the same legal system that I once navigated alone to provide others with the same chance that I was granted. Most recently, I've been blessed with the opportunity to work for DMHA as a peer support manager. I get the opportunity to help manage contracts and oversee our peer and crisis programming at a state level. Today, I no longer have to battle the insane obsession of turning to substances to deal with life's problems. I am free from that bondage. The relationships in my life are nurturing and full of wealth. I surround myself with like-minded individuals who are dedicated to making a positive impact in our society. Since day one of my recovery, my goal has been to shed light on the darkness that so many experience daily. I continue to grow and evolve as a father, son, and a productive member of society. I continue to enter new grounds that I never thought possible, and when I think back on my story, I realize I only needed a chance.
Well, thank you, Andrew, for sharing your story. And lived experience is so important as we as policymakers and our implementers at DMHA work to ensure that we're developing programs that are going to actually work in the real world. So thank you for your work. Thank you for joining us. I think you said you've been here for 2 weeks?
Yeah, about 2 or 3 weeks now.
So we're gonna put you to work real fast. So thank you.
Yes, thank you, guys.
So last year, 86 of our 92 counties opted to receive the historic funding aimed at improving the health of Hoosiers. Health First Indiana was made possible by the Indiana legislature in 2023 using recommendations from the Governor's Public Health Commission intended to expand access to core public health services for generations of Hoosiers to come. I've invited Pam Pontones, our Deputy Health Commissioner at the at the Indiana Department of Health, to talk about Health First Indiana and its ongoing implementation.
All right, good morning, everyone, and thank you so much to Doug for inviting me to be here with you today to share a little bit about Health First Indiana and where we've come and where we're going. And do also want to share Amy Kent is here for Dr. Weaver today. She was instrumental really leading these efforts last year, especially during legislative session. So I am Pam Pontones. I'm the Deputy Health Commissioner for Local Health Services at the Indiana Department of Health. And is the clicker here? Thought this was it.
That's it. It's just the bottom there.
There we go. I might not have been hitting it right. So a little bit of the background of where this got started. And the genesis for the Governor's Public Health Commission, the legislation that grew out of that, and the funding ask is that really coming out of the COVID-19 pandemic really cast a spotlight on public health metrics that could not be ignored. And we know that traditionally Indiana has not fared very well in public health metrics. We do excel in economics and transportation and education and other sectors, but looking at our public health data in a variety of different metrics, Indiana traditionally has not fared well. When you look at the bottom 10 or even bottom 5 of states in a number of different areas such as smoking and tobacco use, obesity, mental health, childhood immunizations by age of 3, overall health rankings, And then if you dive into some of those specific metrics, including high school students using e-cigarettes or vaping, youth with obesity, about a third of our Indiana youth are considered overweight or obese. Infant mortality rate at 6.7 out of 1,000 babies dying before their first birthday. Years of potential life lost due to injury, which a big part of that is drug overdose and suicide, and then heart disease deaths. And you can see that there's a significant room for improvement with Indiana's overall health. Included in that is Indiana's life expectancy. Indiana, traditionally a long time ago, early 60s, was even a little above, doing a little bit better than the national average. By about the mid-60s, kind of really tightly paralleled the national average for life expectancy. And then at about the mid to late 90s, really started to lag behind the rest of the country, creating a 2-year gap in life expectancy between Indiana's average and the national average. And we see that that gap is really occurring in working age individuals, about 25 to 64, whereas other age groups are seeing increases in life expectancy, again due to drug overdose and suicide predominantly. You can also see that there are significant disparities geographically in Indiana, with the #1 county, Hamilton, life expectancy being 81 years, the lowest county, Scott, life expectancy being 72 years. So significant decrease in life expectancy varying across the state up to 9 years. So looking at that data, the kind of long-standing data, and what we were seeing during the pandemic, Governor Holcomb established the Governor's Public Health Commission in August of 2021 to really examine Indiana's public health system, from the Indiana Department of Health to healthcare partners to local health departments to community partners, and leverage strengths, recommend improvements as part of that review. So the commission examined our health outcomes holistically and around 6 key areas of focus, those including funding, workforce, emergency preparedness, childhood and adolescent health, governance, services and infrastructure, and data and analytics. A ton of research being done in those 6 different areas, as well as listening tours, stakeholder calls, meetings, to really get an idea of where public health is in Indiana. That information culminated in 32 recommendations being issued in a report in August of 2022, which served as the impetus for legislation, Governor Holcomb's agenda and budget later that year. So what passed? Senate Enrolled Act 4 was passed through the General Assembly last April, along with the budget bill that accompanied that. Senate Enrolled Act 4 established the process for counties to opt in to enhanced local public health funding and really maintained local control throughout all of that. The budget for this included direct supplemental funding for all of Indiana's, potentially for all of Indiana's local health departments. That included $75 million the first year of the biennial budget, that's this year, 2024. That actually took effect, went into those accounts the first week of January, and then that doubles to $150 million in next year's 2025 fiscal year. Also included some additional funding for our trauma system quality improvement, EMS readiness, our state strategic stockpile, and some programmatic activities at the Indiana Department of Health. But you can see that the main line of funding goes directly toward local health departments in Indiana. By contrast, historically, Indiana's local health departments have had to split about $6.9 million among 95 local health departments each year. So you can see this is significantly higher for direct support to them. But what was key to the legislation is that there is local control preserved so that county officials, the county commissioners, vote to opt in to receive this enhanced funding. That was very important to legislators and to our local elected officials. Indiana is a decentralized state, so public health is really governed at the local level, either county or municipality. Also, the funding is very flexible. So there is not a one-size-fits-all prescription of funding that you often see through federal grants, where there's defined activities that you have to do in order to meet the requirements of the funding. The only real requirement of the funding is that it be used for the delivery of core public health services. And those were defined in the legislation, many of which were already statutorily required, and some being very important that local health departments had already been engaging in. In addition, there were some changes to local board appointments, some other provisions of the legislation, but really historic funding directly to public health to improve service delivery in Indiana. Those core public health services include many of the preventive public health services, again, some that had been required in statute and some that were very important that they had already been providing, with at least 60% of funding being budgeted toward those preventive core public health services, and then no more than 40% of funding being spent on some of the more traditional public health services like food protection and environmental health inspections, things of that nature. One of the most common questions that we get as a result of this funding is, what is the connection to mental health and substance use disorder? Can this funding be used for activities related to those? And although substance use disorder and mental health were not expressly written into core public health services or into the legislation itself, there are definitely connections to them that can be made with the Health First Indiana funding. There are at least 3 core public health services that do relate to that, one being trauma and injury prevention. For example, looking at local health departments engaging community or regional partners in the coordination of harm reduction for substance use, such as naloxone distribution, peer recovery and rehabilitative services, or prevention activities, with our statewide KPI, or key performance indicator, being the number of counties that identified a leading cause of injury or harm in their community and implemented a comprehensive evidence-based program or activity for prevention. So if a county looks at their data and they see that, for example, drug overdose or suicide is a leading cause of injury or harm, then yes, they can use HFI funding toward those preventive or interventive activities. Another core public health service where this intersects is access and linkage to care. Being able to have individuals and resources to connect folks to partners in the community who can provide mental health or overdose-related or substance use disorder-related services. Maternal and child health is another one where local health departments and their partners can provide resources as warranted to individuals, including substance use disorder treatment or services. So again, if there are a few different intersections where that funding can be used. Counties can also, and have been advised to, use their opioid settlement funding in being able to support these activities in their communities and really work with their partners to be able to provide them. So the funding status is, as Doug had mentioned earlier, 86 of our counties opted in as of September 1st of last year. 6 opted out, and those opt-out counties do have the option to opt in if they like by June 1 of this year. And that translates to 96% of Indiana's population being covered by Health First Indiana funding. The 6 counties that opted out will still receive their traditional amounts of public health funding at the state level. And as I mentioned earlier, the new funding became available the first week of January. So we're excited to see that roll out. Now that with the legislation and the appropriation and the funding now coming through to the local health departments, really looking at how we implement this funding and how we can help resource and assist the local health departments to be successful in doing this. So the implementation phase of where we are now is called Health First Indiana. That's for a couple of different reasons. Number one is this is the first of its kind funding for public health in our state. This is truly a historic time. And secondly, we know that by putting health first, that folks are able to work better, they're able to learn better. We know that businesses look very carefully at the health of a community when they decide to locate a manufacturing plant or an office complex. We know that students learn better when they are healthy and they feel good. So the investment in prevention, we know, leads to healthier communities and workforce. That in turn benefits businesses and benefits our economy. This is truly a partnership. Local health departments are encouraged and in fact really expected to convene their local health elected officials, public health partners, clinical health partners, community organizations, because those partnerships allow communities to organize care, reduce duplication of services, and really be more efficient. They can essentially force multiply the impact in their communities. This is also one of the largest rural or investments in rural communities that often have fewer resources, especially in the public health space, and really develop innovative solutions that are tailored to them. So the communities look at how they can implement this funding. There's no prescriptive formula that you have to do this core service or you have to implement this programming. It's really looking at what the community needs are and tailoring the funding to that. So a little bit about our new website that launched. Ask you to check it out. It's healthfirstindiana.in.gov. This launched the first week of January along with the new funding. And what you will find there is the opt-in map where you can see counties that opted into the funding denoted in green, those that opted out denoted in blue. We have a new logo that we have branded with the Health First Indiana initiative, and also have created a toolkit for counties to use to be able to brand accordingly what they're doing. So you can see a little bit about what the funding is for each, for the state, and then by clicking on a county, you can get a breakdown of the individual budget, whether or not that county opted in, what their legacy or traditional public health funding has been, what they receive in 2024, what they would be expected to receive in 2025, or the second year of the biennial budget. And there's also a link to the county budget on there as well. So it's very transparent that partners, stakeholders, the public can go in, click on that, and see the budget that was submitted in terms of the Health First Indiana funding. Just a quick summary of the county budgets that we received last fall. 78% showed that the funding is going toward prevention and health outcomes. So 78% of the funding among all of those budgets going toward prevention and health outcome core services, with about 22% going to those more traditional core public health services. At least 66 of the counties were already planning or had already started partnering with community agencies in this first year to provide core public health services, and several different examples such as mobile clinics, partnering with their hospital systems, community paramedicine program, fitness and nutritional support, AEDs for community buildings and schools, car seat safety, safe sleep, education, and resources. A lot of really taking services to where people are, which is really critical when we look at access to public health services and linkage to care. Also, what you will see on the website is data. So counties being able to have county level data at their fingertips to help them prioritize and determine where this funding is best used. So we have put 7 different public health indicators on the map. You can click on the upper right and choose the indicator that you wish to see. Those include adult obesity, childhood immunization rates for children under 3, infant mortality rate, life expectancy, adult smoking rate, suicide rate, years of potential life lost due to injury, which again has real roots in drug overdose and suicide. Each county is ranked 1 to 92 there on the right for each metric that you want to choose. If we also include the state rates and the top 5 and the lowest 5 counties there on the left. If you click over a county, if you select county at a glance at the top right, it's not wanting to. Uh-oh. There we go. Whoop. There we are. If you click on the county at a glance on the top right, you'll get a scorecard with each of those 7 different metrics and the county rate compared to the Indiana rate, and then the ranking of each county and where those counties fall in those 7 different areas. Again, very helpful to be able to provide county-level data to local elected officials, local health departments, their communities, to really make data-driven decisions. We're planning on expanding the number of indicators that we include on the scorecard and also updating the data, getting more recent data for some of the indicators like infant mortality, doing more drill downs into variables like age, race, and ethnicity to really see where implementation of preventive services, linkage to services can really be targeted. Woven throughout the legislation, and certainly very important to our legislators and local elected officials, is accountability and transparency. This is a significant infusion of taxpayer dollars, and we want to make sure that we are putting them to good use. So woven throughout the legislation is that accountability and transparency factor. Counties are required to submit an annual financial report before that funding is approved for the next year. So in addition to the budget plans that counties submitted last year, they will submit a report this year, each of the following budget years, to show how money was actually spent. Counties will also be required to report twice each year data on how they are achieving the state-level key performance indicators to measure delivery of core public health service. And then we also, as you saw on the website, have very transparent posting of county budgets, core service capabilities, county data, so that the public, stakeholders have this right in front and it is refreshed and updated routinely. A little bit about the key performance indicators. We have developed a core public health service tracker for local health departments to report their data for not only the services they provide, but also the key performance indicator data. We will also be assisting counties in developing their county level key performance indicators by December 31st of this year. We will also be creating dashboards and tracking mechanisms to track public health outcomes and public-facing dashboards. We will also, at IDOH, be submitting an annual report to the General Assembly and presenting to the State Budget Committee, also on the progress that is being made using this funding. One way that we are resourcing local health departments and providing technical assistance is through the regional teams that we are building out. And those regional teams, which we should be rounding out by the end of this month, include service support for data analytics, core service delivery, which might be what programming is recommended, how do we convene partners, how do we build relationships, finance for budgeting, contracting, invoicing to make those processes smoother, clinical support, how they can link folks to care. What are those intersections with local public health nurses, immunizations, outbreak investigation, and then also building in communication support and legal support as well. And we heard from local health departments during the pandemic and through the discovery phase of the Governor's Public Health Commission that those supports would have been very helpful for them. So wanted really to meet those needs that they mentioned. So at this point, we're full steam ahead in implementation. Also, though, noting that the nation is watching. Several other states have reached out to us asking what we were able to do, how did we do it, so that they can look at how they might be able to implement something similar in their states. So I think there were several different drivers of success and how this was able to be passed and be able to get the funding. Really talking to the right people, gathering folks on that commission that Governor Holcomb created was outstanding. Showing the data, whether that's life expectancy, health disparities, speaking to a variety of constituents and folks, including the public, on the listening tours, legislators, local elected officials, businesses, schools, to gather that support, and then preserving local control and flexible funding as key elements of this effort, and then showing return on investment. So for future planning, our next steps, and there are several, but some highlights for you: developing the templates for budget plans and reports, county level KPIs, conducting district workshops that have been underway since last year to help local health departments dive into really what the core public health service delivery looks like and effective planning to be able to implement, continuing to use data to track long-term impact on health outcomes, and then our subject matter experts engaging with local health departments and their partners to see how we can improve in those different areas. So I will go ahead and stop there, and if we do have time for questions, I'll be happy to take any that you have.
We do. Are there any questions? I know I have the Health First website bookmarked, and the county level data is incredible. To have it all in that one place, and also have the budgets for each county to understand where they're investing has been incredibly helpful as we go in to have those conversations.
Great. Thank you so much for that. And I know with Dr. Weaver, transparency is a priority. Making sure that we can get information out, that it's right there. Big credit to Greta Sanderson, our Chief Communications Officer, who really helped develop that website, worked very hard with her team and our subject matter experts too.
Any questions? Chris?
Pam, how engaged are the counties in establishing their KPIs? I mean, is it something that they're interested in, taking, a great effort in trying to do that? And is it just the public health officer, or is there discussion broader than that in the county?
So in terms of county level KPIs, some counties have actually started thinking about what those county level KPIs can look like. So we have our overarching state level KPIs, which are really capacity driven this year, because we know that local health departments will need to expand what they're doing, work with their partners, be able to establish those relationships. So they're really kind of yes, no at this point. Those will evolve into more metric-based KPIs as we go further. But counties have already started looking at how they can develop KPIs to meet the state level KPI. That's how we want that to go. We are now in the beginning of this year starting to walk down that path and see how we can partner with local health departments to do that. So we've convened what we call a core leadership committee, which includes representatives from several local health departments, academic public health partners, our subject matter experts, to start now looking at how do we build those out so that we can meet that deadline by the end of the year. And if we can do that sooner, that's great. But really maybe develop a menu of KPIs to help counties see what they could do and be able to do that very well. Does that answer your question? But we see some already engaging in that.
Senator Yoder?
Thank you so much. Thank you for your presentation. We've been speaking or spending a lot of time in the legislature, at least the Senate has, and it's going over to the House, issues of reading proficiency. And I keep saying we should have the Department of Education and the Department of Health, those counties who opted in, sort of putting the map over where the lowest reading proficiency is and do some partnership and some education and prevention work, because there's this connection of literacy to health. And if there could be some outreach and education in these two areas of the state, I think that would be great for education and the Department of Health to be in communication.
Great, thank you.
Yeah.
I appreciate that. Thank you for your suggestion. We can take that back.
Any other questions? Well, thank you so much for sharing and for all the work that your team at the Department of Health is doing.
Thank you so much. I appreciate the opportunity.
So, a core piece of public health is mental health, and we've made some significant strides here in Indiana in the mental health space in transforming our behavioral health system to help serve our most vulnerable Hoosiers, but also create better linkage between the behavioral health and other community pillars. So we've invited DMHA Director Jay Chaudhry to share an update on the division's priorities as they continue to build out Indiana's behavioral health system. Jay?
All right, thank you. Thanks for the invitation. Happy Groundhog Day.
Early spring.
Apparently there was no shadow scene, so I think that's good. Right, so, and kind of fitting, I think, with Groundhog Day, if you talk about the movie Groundhog Day, it's about somebody that lives the same thing over and over again forever until he figures out, a different way out. And I think there's somewhat of an analogy to be drawn on the fly right now, so apologies, with sort of our approach to behavioral health in Indiana over the last 10 to 15 years, where there's sort of been nibbling around the edges until, Governor Holcomb and Doug kind of came in and decided to kind of blow things up and put them back together as it came to SUD. And I think we're seeing the results right now. And I'm here to talk today about kind of our plan and hopes to do the same thing with mental health. So, wrong button. So, as Doug said, I'm the director of the Division of Mental Health and Addiction. I can't go any further without acknowledging my staff that showed out in pretty big numbers today. So it's been a lesson in leadership over the last several months of just sort of getting out of the way and letting them get to work, because this is all I think they're doing, and they're a credit to sort of their dedication and hard work. And so behavioral health is understatement of the day, complicated, right, and complex. And obviously there's a whole lot that go into sort of mental health and mental health outcomes that we at the state have no control over, right, or very little control over. And so I think, like, at the beginning, we've approached this with a certain amount of humility and understanding that, there's things we control, things that we don't, and we really need to focus on what we control. You're probably familiar with the Serenity Prayer from recovery, and that's kind of our operating philosophy as well. Like, we focus on what we control and do everything we can to build that, and also understand there's things we don't control. So at the state, what do we control, right? So we provide funding. We can set standards to a certain extent and enforce those standards, and then we can build infrastructure. And so really, we've made the centerpiece of our work over the last few years on focusing on building that infrastructure for the long term, right? Because ultimately, to us, building infrastructure, and we'll get into what some of those pieces are, is really about sustainability. It's about what do we do, not for the Hoosiers of right now, but as much for the Hoosiers of 2035. 10, 11, 15 years from now, what can we do to ensure that the things we're building right now and the things that were built started last legislative session will continue? And our answer to that is we need to, as much as possible, wrap them into a sustainable infrastructure. And this is where some of the tension comes in, right? So, and I think Pam alluded to this as well, where that sort of tension between local control and flexibility, which is so important, right? That's the key. Like I said, we can only do a few things at the state. Everything else has to be done locally. but we have to maintain kind of certain minimum quality standards, certain requirements in order to have all those local efforts roll up into a system that can be sustained over the long term, right? And the system is underpinned by Medicaid, and Medicaid at its core is a relationship between the state and the federal government. So the state has a role to play, and what we're trying to navigate and figure out is what can we do to fulfill that role and maximize that role, while also understanding that ultimately, like, local collaboration has to drive a lot of what we're doing. And so the last legislative session was huge for public health. It was equally huge for behavioral health. The first major investment in behavioral health in a long time in the state of Indiana. And we're going to talk a little bit about Senate Enrolled Act 1 from last session, and two things in particular: the certified community behavioral health clinic model, and I promise we'll unpack that in a bit, as well as the crisis response system that's built on the back of 988. And so those are the two main things we'll talk about today, but I just wanted to also flag HEA 1006, not forget about that. That is working to start the process of detangling behavioral health in the criminal justice system, because the unfortunate reality is that the criminal justice system is our #1 behavioral health provider, not only in the state of Indiana, but nationally, and we all need to start unpacking that. So. All right, so the crisis response system is just like it sounds. This is a new way, a new approach to responding to behavioral health crises. Right now and historically, the main place where people in mental health crises end up is the jail or the emergency department. And neither of those places are great places to be, either for the people in the crisis or the people that are working there. Sheriffs will tell you that their #1 problem and has been for a while is mental health, and I think the emergency rooms will tell you the same thing. Like, we are not equipped to deal with this issue. Law enforcement will tell you that they don't want to go out answering what are really health-related calls if they can avoid it. And so this system is built in 3 parts: someone to contact, which is a new number called 988, and we'll get into that in a little bit. Someone to respond, which are mobile crisis teams, and so these are behavioral health first teams that go out into the community and respond to crises in action, kind of where they happen. And then the third pillar is somewhere to go, which is a crisis stabilization unit, which is a physical location that's intended to address situations that can't be more successfully resolved over the phone or in the community. And we're working on building this system. The data from places where this system has been implemented, mainly Arizona, shows about 70% of these cases are resolved in the community, and our emerging data locally in Indiana on some of our pilot sites reflects that same thing. And so you think about that from a system sustainability transformation standpoint, and these are situations that would have ended up in the jail or emergency room that are now being resolved successfully in the community. I did want to flag, and thank you so much, Andrew, for sharing your story. We are very much centering lived experience and peers in this system. The peers are sort of the key to crisis stabilization, because the phrase "I've been where you've been" is really powerful, right? And so the only thing we're doing from a mandating standpoint is we're mandating that peers have to be on mobile crisis teams. The other composition of those teams we're leaving up to local communities. So as part of Senate Enrolled Act 1, there was a new appropriation created called the Community Mental Health Fund. We really need to come up with new names for these things, because I think it's really confusing, but this is a new fund, $50 million a year for crisis response and CCBHC. And just to give you a little update on the progress of spending these funds, as you can see, we've obligated about $28 million of this funding onto contracts for organizations that are community mental health centers currently that are eligible to become certified community behavioral health clinics, and I will unpack that distinction in a little bit, to provide services for kind of part 2 and 3 of that system. So crisis stabilization units, as well as mobile crisis teams. And these cover the entire state geographically, not the whole state, but it's a pretty broad mix of urban, rural, suburban, kind of covering all types of the state. In theory, we have about 88% of the state covered, but I think more realistically, our goal is to cover 50% by the end of the biennium. And an example of how this works in practice, Senator Yoder, since you're right here, is in Bloomington. So we have Centerstone, is providing mobile crisis, and they're also running an organization called a place called Stride Center, which is a crisis stabilization facility that I think was initially sort of developed more on the SUD side, but now is sort of merging into more of a behavioral health holistic focus. One of the pillars of our crisis response center is the concept of no wrong door, which, just like it sounds, it means that no matter who you are, what your diagnosis is, what your background is, what your ability to pay is, our system is designed and built, and our expectation is that they will take you in, figure it out, and get you to a better place, which is an ambitious goal, and is one that I think is not necessarily how the system's been run. So I think as we're building it, we're working really closely with our providers to make sure that is how people experience the system moving forward. A couple other things, we're also building what's called a mobile crisis accelerator. So this recognizes the fact that in some places, in some population centers in particular, there's a need for specialized mobile crisis. Now, ideally, every county in Indiana would have access to like their sort of perfect, ideal situation for what they need. That's not realistic, just given workforce and sort of other challenges. But we do know, like for example, individuals with intellectual disabilities are increasingly behavioral health crises are increasingly being composed of people who have intellectual disabilities, autism, things like that. And so, we're working with a group to develop an accelerator program to address that population, to address sort of the historic challenges, with the African American community and law enforcement. And so how do we build responses that meet those community needs? And then we're also just starting conversations on sort of like, how do we make sure that these regions collaborate with each other? Because mobile crisis and crisis response is inherently regional. It's geographic in nature. You can't have a mobile crisis response in South Bend that can respond to a crisis in Indianapolis. Just doesn't work because of the geographic reality. And then I think we're proud of the fact that we've only spent about 1% of our costs, we plan to spend 1% of our costs on administrative overhead. This is a new system, but this team is making miracles happen, so I'm really proud of that. So let's talk a little bit about the first part of that system, the 988 call center. And so we are really proud of this, and this is a credit to our DMHA staff as well as our call center staff. Really quick history, so the call centers in Indiana were historically, forever, completely volunteer operated. We have in the last couple years switched that and given them quite a bit of federal funding to hire actual paid staff, which is our investment in those call centers has paid off. We have a top 5 answer rate in the country in terms of in-state answer rate. Now, the calls that don't get answered, because I get this question a lot, they still get answered, but they get answered by a national backup. So people still get a response, but I think it's really important. It's really a goal of ours to get those calls answered in-state, because the in-state call centers are the ones that have knowledge of sort of community resources and things like that. So we're really proud of this. It's a testament to our call centers and our team. Big part about 988 is getting the word out. I'm in way too many rooms. I ask people to raise their hand if they've heard about 988, and a lot of hands stay down. It's not unusual. If you're familiar with the development of the 911 system, it took a long time before 911 became kind of ingrained in people's minds as the thing to do when you have an emergency. And we're in the same boat with 988, but we've developed really thoughtful messaging and working with great partners to develop some of that. And so really quickly, I'm going to, if this works, show a video with a brief message about 988 awareness.
What is 988?
It's a free 24-hour suicide and crisis lifeline.
What is a crisis?
Maybe it's something you experience so often.
You don't even think it's a crisis.
Anxiety over money.
A stressful relationship.
Concerns about a loved one's mental health.
If you're experiencing thoughts of suicide or a mental health or substance use crisis, call or text 988.
It's a listening ear.
And it's a way forward.
So you'll see materials, 988 materials, hopefully a lot more places as we build out our awareness campaign. And if anybody wants more information, there's a QR code there, but we'd happy to talk kind of offline about other places and avenues to get the word out about this life-saving service. So that's the crisis response system, and it is related to the other big change from Senate Old Act 1, which is CCBHC. Now, I wish that it was a lot different than CMHC, which is our current model, but let me just get the definitions out of the way. CCBHC is Certified Community Behavioral Health Clinic, and this is our preferred model to replace what is currently built on the CMHC system. CMHC is Community Mental Health Center. So we currently have 24 CMHCs around the state of Indiana, which have kind of their individual catchment areas and are our safety net. And many of them and most of them are transitioning to this new model. And we'll get to the kind of why, but let's just talk about the what before. So this is a model that developed about a decade ago after a long kind of gestation period in a variety of states, because I think many people realize that the kind of old fee-for-service model of behavioral health care in particular, which is again in line with other healthcare trends, but in behavioral health care was not meeting the needs of communities. The history of the CMHC system goes back to President Kennedy, who signed the Community Mental Health Center Act in 1963 with sort of the promise of emptying institutions and then being followed up by robust care in the community. That robust care really never materialized to the extent that it was predicted to. And so around the country, people were looking, how do we address this? How do we bridge that gap? And CCBHC is what they came up with. And this has been tried a lot of different places since 2014 and kind of across the board. It's been proven to increase access, increase workforce, reduce wait times, reduce criminal justice involvement, reduce emergencies, reduce ER spending, reduce inpatient spending, which is one of the main drivers of cost for behavioral health. And so we are excited to leap towards this model. Now it's a lot of work, and so, but you know, that's the big picture why of what we're doing it, and we'll get to the kind of like the more specific why in a little bit. So the core of CCBHC, similar to public health, we have core services that every CCBHC has to provide, and these are you know, kind of laid out up there. I won't read all of them, but this is the entire continuum of care. This is everything a person in behavioral health crisis can need, and our CCBHCs have to be able to provide these services, but more importantly, in some ways, they have to be able to demonstrate that they're providing these services, and we have to be able to prove it. And that's been, I think, the biggest the biggest learning curve for both us and our providers is not only do we have to, you know, have these services available, but our data systems and our and everything else has to catch up. To be able to show definitively to the federal government that we're providing these services. So that's the what. I do want to talk about the why, because I think one of my failures, I think, in the last year or so has been not clearly articulating, you know, what sociologists call the theory of change behind CCBHC. Like, what is it exactly that we're trying to change, and how will this make it happen, right? And so Dan Evans knows, you know, healthcare is built on a formula, right? That formula is a mix of patients, payers, and services. And I don't think it's fair to say that the formula drives decisions in healthcare, but I think it's probably fair to say that that formula represents the kind of outer limits of services in healthcare, right? So everything has to happen within the confines of that formula. And the CMHC system over the last decade or so has been squeezed, that formula has been squeezed a lot by sort of level funding and greatly increased costs. They're similar to other healthcare conversations, but in CMHCs it's been pretty acute. And so there's no flexibility right within that formula. And so there's been a lot of talk about, like, you know, well, you know, can't we just make a tweak here or a tweak there? And so the other analogy that I often like to use is the notion of an operating system. So, you know, your phone, you have an operating system, and you can have wonderful apps and wonderful software built on that operating system. But ultimately, if your wonderful app doesn't have an operating system to support it, it's not going to work. And so our operating system, because of that formula, is not able to support the innovations and creativity and services that our communities need. And so the why that we're doing this, and, you know, why don't you make tweaks here, why don't you make a little tweak there, is because I think we tried and we kept running up against a complete just wall because of that operating system and because of that formula. And so what CCBHC does, in a nutshell, is it allows us to create a new formula. A formula that's driven by what's called a PPS rate, or prospective payment system rate. So the centers will deliver the services that we require, they'll capture their costs, they'll survey their community's needs, and they'll build a rate based on those actual services and those actual needs of the community. And that will be how we pay them. And so, in particular, that will allow us to build tailored treatment pathways for people. Think about somebody with severe mental illness. This is a really complex person with massive social needs and a complicated relationship with their family, and the medical and psychiatric needs are not necessarily straightforward. And so our current system, because of that formula, kind of requires our centers to fit them in kind of a one-size-fits-all approach. This will allow us to build tailored treatment pathways for people, which is the thing that we're probably most excited about. It can also strengthen the whole ecosystem. Again, the core of CCBHC is what's called a community health needs assessment, where every 3 years our centers have to, similar to healthcare, have to look at their community's behavioral health specific needs and continually operate and update their operating system based on what that community actually needs. And so that includes partnerships with courts, partnerships with child welfare, partnerships with schools. This system actually has a model to support all of that. And then kind of going up to the top, the complete transparency. I mean, Dan, you and I have had, not to pick on you, but we've had conversations about like how, where's the data? What does the data say? And like I tell you, the data doesn't say anything meaningful, right? And that's part of the problem with our system, is that the data is so opaque, and CCBHC is built on a requirement of kind of complete transparency on a whole host of measures that we have to be able to not only get from our centers, but then turn around and report those to the federal government. And so it will force us to have that transparency in data. And so that's the why of CCBHC and how we think it's going to change things. And that's reflected by where it's been done. So just a couple things about the how. I mean, our big push right now is what's called the demonstration program, which is a federally funded pilot program that is competitive. And so we're one of 25 states that's eligible to apply for this in March. And all of our work and our team's work has been focused on this application. And so we'll find out in June if we get it. And if there's 10 states that are going to be awarded this, and if we are awarded it, then we'll get enhanced federal match for a period of 4 years to pilot this with our sites. And so in order to select those sites, we introduced a fair amount of competition into the system, which I think, again, has been sort of lacking. And so we selected 8 sites that are going to serve as our pilot, our backbone of this demonstration. If we get that, that's going to be our approach. If we don't get it, we have another approach. And thankfully, a lot of the work that we've done for the demonstration can easily be pivoted to this other approach. And that would be a state plan amendment, which would change our state Medicaid plan to incorporate CCBHC into our system. So just to end on the individual, I mean, that's the most important person in this conversation, are the people that we serve. And so just the composite member of our community named David, I won't get into a whole lot about him, but this is a pretty standard patient in our system. And you can see, like, a whole lot of trauma, a whole lot of stress, good relationship with his family, which I think is again, there are so many families struggling too with mental health. It's not just the people, it's families that are struggling. And so, a complex combination of mental health, physical health, stress, basic needs, that sort of thing. And, it leads to David kind of having some issues in public at a gas station. And you see 911, police, ER, jail, and he ends up in the criminal justice system. And that's unfortunately the case for David's all around the state of Indiana right now. And our future state, because again, you don't get where you're going if you don't have a clear vision of where you want to get to, even though this is years and years away probably from being a reality, is a much more linear path that starts with behavioral health first, and it results in David never entering the justice system because his needs are being met in the community. We know this is not happening right now, and one of the ways that we know is through a single data point. That's the number of people in our state that are found incompetent to stand trial, which is a sort of an indicator of the overall health of the system. And that number has increased from 125 in 2012 to 535 in 2024. And so that reflects the notion that our justice system is not, or our behavioral healthcare system is not operating to the level it needs to avoid situations like David's. And that's why this is our end goal. And with that, I'm happy to take any questions.
Questions? Senator Yoder.
Thank you so much. Great presentation, and thanks for all that you do. I wanted to go back to David, because one of it's not a lot of people, but there are a few people that maybe present themselves, maybe the private episodes of psychosis isn't there. But communities have individuals that perhaps they are more transient, they're not housed, they want to be, they're not interested in, maybe the only presenting thing is, I don't want to actually live with other people, but we don't have a place for those individuals, and communities are left with, there's no reason to put you in the jail. You're not presenting in a way that we would admit you into the ER. They're not eligible for the Stride Center. And so what do we do with these Davids? And how do we best care for them? What are our options? I know that one of the conversation that I've had with some leaders in my community is how we define how we're able to hold people. I know California is trying to deal with this issue as well. I don't know if I've made myself clear.
No, I mean,
you're nodding, and I'm thrilled about that.
You're raising a whole lot of issues that I think are, again, really complicated, hard to unpack. I think there's a couple of things there I'd point out. Number one, I think with CCBHC, there's a specific modality, and I'm a lawyer, so the clinicians might run up here and tackle me if I get this wrong, but the modality is called assertive community treatment, and the notion is that this is where we send teams out into the community that have like regular, frankly, daily checkpoints with some of the Davids in the community. And I don't think it's a coincidence that our incompetent to stand trial rates started skyrocketing when we stopped offering assertive community treatment, for example. And so, because what that does is that private psychosis, I think it makes it a little bit more known to everybody, and it allows us to realize, before it's too late, before he's running down the street, in obvious anguish and psychosis, can we stop it before then? And so the system will allow us to get more upstream, right, which I think might help. You pointed out housing. Point to Jake there. I don't know. I mean, that's a huge issue. I think we all know it is for folks in our communities. But then the notion of involuntary treatment is one that I think we need to continue to have really hard conversations. I know, Chris, you and I have had conversations about, it's just a fine balance between public safety, individual rights, and there's not really any easy answers, but I think that if we can continue to have sort of ongoing conversations about the nuance required there, because the truth is it's not a crime to just make people feel weird, right? Mm-hmm. But that's, I think, so anyway, there's a lot there. I don't think we can solve it today, but I think it's a really important question. Thank you for asking it.
Jay, thanks a million, and thanks to your staff. There are a few people like me who've had the opportunity to watch you work over the last several years and watch your staff work, and it's much appreciated. So I'm going to ask you a data question.
I figured, right? Yeah, bring it on.
Your slide that says the contacts to 988.
Yes.
Routed to Indiana, answered in-state answer rate. Yeah, so you're collecting a lot of data, right? Yeah. A ton of data. So I do the math in my head, if I'm doing it right, that do I add the routed and the answered to get the total number, or is the answered a subset of the routed?
That is let's see.
In other words, is it 131,000 calls?
No, sorry. It's the total is the I think you add them together, right?
It doesn't matter. That means there's hundreds a day, right?
Yes.
There's hundreds a day.
Yeah, the routed is the.
Doesn't matter if it's twice the number,
it's
it's hundreds
a day, absolutely, yes.
Yeah, so here's my question. Do you have now, or will you have in the future, efficacy data? That somebody
Efficacy
calls with suicidal ideation.
So that's tricky
David
because
calls with suicidal ideation. According to this map,
Yes.
he's isolated from his family. So he's calling this number because he's seen that ad, right? That's the hope. And he is steered to another course of action. As you know, I work with 3 children's homes full of Davids, except they've fallen through the cracks, and the suicidal ideation has spiked through the roof. I mean, you tell me it's tripled, at least tripled. So I'm trying to figure out the used and useful part of this. How do we use this data? And how is it useful at the local level to get upstream? So that David isn't making the call. He's getting the intervention now in Bloomington, Indiana, that has spectacular mental health services. But because we ran a hospital in Bloomington, I can tell you it also has an incredible suicidal ideation issue. So does Tippecanoe County, by the way. It must be the students. I don't really quite understand it. So I would get the calls after the fact from mom saying, why didn't you save my child's life? Me. So I get it. There was no intervention when the mobile action team picked up the kid, took him to the ER that's not designed to do that, and so they stabilized him and discharged. So that's a long-winded, baggy question. So Jay's heard this before. So the data, do you have a concept now of how we might use that data? Now I'm thinking bigger. We've got this public health money going on right now. We've got the counties working with the state on the KPIs right now. Can we use this data to say your county got 2,700 phone calls last week and 10% of those were real suicidal ideation, so you got 270 of them last week. Divide that by 7, so you got 6 or 7 a day last week. What do we do?
So the biggest barrier, and I'll talk about what we can do, but the biggest barrier to this is 988 is anonymous, or is allowed to be anonymous if that's what the person wants. And that's not just their name, it's also where they are. So we don't press people for any PHI or any identifying data. And that's sort of a core function of the system. I think it has to be, because I think, we want no hesitation whatsoever to call 988, but as you can tell, that's an inherently limiting principle when it comes to using the data, right? Because we do track, and then I think, we know the numbers that call, we know the area codes those numbers come from. I don't know.
You've got loads of de-identified.
Yeah, and so I don't know, and I don't if we can track down to the sort of the I think there's conversations nationally about geolocation that are fraught with privacy concerns. I think that is still a conversation that hasn't necessarily been resolved yet. But I think that we recognize that we are sitting on somewhat of a mother load of raw information, right? So how do we translate that into things we can use with the really important limitations of privacy, of anonymity, and those sorts of things? I don't think we have a clear answer yet. I mean, we have metrics for our response system that we want to see happen. I think once it gets to the other parts of the system, the mobile response and the crisis stabilization, then that enters the healthcare system, and therefore we do have a lot more data that we can use there. But it's complicated for the reasons that I brought up. But it's questions we're having constantly. In general, I think with the overall health of our system, I think and this is where we're trying to get to, is like what are indicator data points that we can sort of use, or I use ICST as one of them. There's probably other ones, and that's, I think, where we're trying to get to, like sort of how long does it take somebody to get into services, things we control, because ultimately, like outcomes, and again, I don't mean to downplay the importance of tracking outcomes, but outcomes are so dependent on the entire universe that a person has, like their social determinants, their family relationships, their all other things. Like we need to number one, make it easy to access, right? That's our North Star, because that's what we control. But it's a great conversation, and I welcome your further thoughts on it. Thanks, Jim.
Other questions?
Not so much a question, I guess more of a statement. You mentioned Arizona, and I was fortunate last December, I was at the Summit to Advance Criminal Justice Priorities, and Arizona was there presenting about their mobile crisis units and what they're doing. And if that's the direction that we're headed, I'm just really excited about it. The outcomes, the data that they had, like they're doing some amazing things. And in my world, I see the first version of David, and that's who we're dealing with on a daily basis. So just really excited to see this progress, and looking forward to hearing more about it.
Yeah, thank you.
All right, well, thank you very much. So, So now more than ever, we're entrusting locals with the responsibility of leading initiatives, providing both the structure and the funding for community-driven solutions. And I know as I travel the state, as many of you also meet with locals across the state, they're continually asking us how all of this work is connected at the state level. So my goal in having Deputy Commissioner Pontones and Director Chaudhry present today was to convey that the full integration of our collective efforts. We're not just talking, we're actually working together to understand the touch points and the systems that we're building, and then conversely, how those have an impact at the local level. So we have really important work to tackle, and no single entity at state government or at the local level bears responsibility for it. And that's why it's so important that we collaborate at all levels, not just the state level or locally within a county, but also regionally across our state. So I want to thank all of our presenters this morning. I appreciate everyone's time and attention. Our next meeting is May 2nd at 10 a.m. here at the Indiana State Library. We stand adjourned. Thank you.